I'm Dr. Chowdhury. Welcome to FSMB Spotlight, where we have conversations about healthcare, especially those related to the state-based licensure and discipline of our nation's physicians and physician assistants. Our guest today is Dr. Ralph Loomis, the treasurer of the FSMB, who is also chairman of the FSMB's work group on team-based regulation. Ralph is a neurosurgeon from Asheville, North Carolina, where he was chief of surgery at Mission Hospital. He joined the North Carolina Medical Board in 2009, serving as its president from 2011 to 2012. Ralph, welcome to our show.
Thank you, Dr. Chowdhury. I'm happy to be here.
Before we talk about the FSMB and your FSMB work, let me ask you about how and why you got involved with the North Carolina Medical Board in the first place several years ago. As a practicing neurosurgeon, a husband, and a proud father of 6 boys, how do you manage it all?
I became involved because I felt it was very important that physicians play an active role, not only in protecting the public, but in regulating the profession. How does it happen? A wonderful wife and 5 excellent partners who cover when I travel.
An understanding wife, I imagine.
Absolutely.
Well, I admire your time management skills. Let's talk about this FSMB work group that you chair. Many people nowadays know, I think, what we mean by team-based care. It's a doctor, a nurse, a pharmacist, for example, and others working together to deliver quality health care to a patient. What in the world is team-based regulation?
Team-based regulation is truly a collaborative effort among various health-related professional regulatory boards, state-based, to optimize strategies to deliver their product, which is protecting the public.
So I know in team-based care, when something goes wrong, it's sometimes difficult for the patient to figure out who to go to figure out where they can get some recourse. So how does team-based regulation help with that?
We hope to set up a mechanism so that it is easy for patients to learn and set on where to go with any concern or complaint, to have it handled readily.
And I know you're trying to also encourage the state medical, nursing, and pharmacy boards and other boards to collaborate and work together when they're trying to do their best to protect the public.
Yes, if we can have a joint effort, then it would be a whole lot easier for the patient.
Okay, very good. We have a nice picture of the work group when it met at FSMB's offices last year in Euless, Texas. Aside from you and me, the work group, not all of whom are pictured here, includes Dr. Claudette Dalton of Virginia, a member of the FSMB board, Kathleen Haley of Oregon, Lyle Kelsey of Oklahoma, Susan Siasek with the National Association of Boards of Pharmacy, Dr. Louis Pruz of Michigan, Jean Rexford of Connecticut, who is also on our FSMB board, Kathy Thomas with the National Council of State Boards of Nursing, Dr. Cheryl Walker McGill of North Carolina, also an FSMB board member, Dr. Art Hengerer of New York, our FSMB chair, Dr. Dan Gifford of Alabama, our FSMB past chair, Dr. Gregory Snyder of Minnesota, our FSMB chair-elect, Lisa Robin, FSMB's chief advocacy officer, Shiri Hickman, FSMB's Director of State Legislation and Policy, and Natalie Weiner, FSMB's Legislative Assistant. It's a large group, isn't it? I mean, you want to make sure you do this right. But I assume the inclusion of a nurse and a pharmacist on the work group by Dr. Gifford was intentional?
Yes, I think Dr. Gifford saw it essential to have all the players at the table in setting forth an agreement of collaboration.
Very good. Now, while the final recommendations of this work group have not yet been sent out for feedback and comments from the state medical boards, I do know that the report plans to include several references to best practices in team-based regulation at several state medical boards across the country. Can you give us 1 or 2 examples of that?
Minnesota has long had statutes that have directed their health regulatory boards not only to share investigative information, but to share other information such as discipline history among the boards. Other states have also followed that example. North Carolina has gone further than that. They have statutes that direct the medical board and the nursing board to have a joint subcommittee that meets when needed to review not only rules for those performing medical acts in North Carolina, but to revise those rules and then also to review individuals that maybe were felt to require some disciplinary review. 11 years ago, they set up a joint subcommittee with a pharmacist. And both of these, both the nursing and the pharmacist, have representatives from both boards, equal representatives. So therefore, any act by a clinical pharmacist practitioner in North Carolina can be brought to this joint subcommittee. They've met for 11 years, and we have a lot of experience in North Carolina with how that comes out.
So Ralph, you identify these as best practices. Someone watching may assume that every state has these sorts of arrangements where the boards get together, but that's not necessarily so, is it?
No, that's not so, and it's not necessarily needed. There are many states that really find this not to be something that would be useful in their regulatory environment. And therefore, at the Federation with this committee, we're simply trying to provide alternatives that might work in different regulatory venues.
But it's really up to the states to decide what's good for them.
Totally up to the state.
Ralph, we're out of time, but let me thank you for being our guest and for sharing what's going on with one of our work groups. Best of luck to you in the months ahead and tomorrow when the work group meets, correct?
Correct. Thank you.
Very good. That's all we have time for. Thank you for joining us. Stay well and see you next time.